Thank you, Nadika. Right. Our next speaker will be an online speaker. Dr. Patrick, can you hear us?
Do you hear me?
Yeah, we can hear you. Let me first introduce you to our audience here, who are mostly nurses. Our next speaker, Dr. Patrick Weber, is connected to us from Switzerland. He's a nurse by training, and he has an MA in healthcare management. And he is the CEO and a shareholder of NICE Computing SA, working on quality control for DRG in Switzerland and promoting nursing workload measuring system in Switzerland, Germany, Austria, Italy, and some others to come. And at the International Medical Informatics Association, he is the Vice President for the conference MedInfo 2019 to be held in Lyon, France, and is a member of the board of IMIA Nursing Informatics promoting in 2018 in Mexico. And at the European Federation of Medical Informatics, he is a member of the board and a past president. And he's also a founder member of the International Academy of Health Science Informatics. And he is also a member of the board of Nursing Informatics in Switzerland. Further, he is the president of Olivier Moeschler Foundation for Pre-Hospitalization Emergencies, and is also the co-editor of 2 volumes of Nursing and Informatics for 21st Century, an international look at practice, education, and electronic health record trends, and Nursing Informatics 2016 post-conference book, Forecasting Informatics Competencies for Nurses, the Future of Connected Health. We are quite fortunate to have Dr. Patrick Weber here connected to us online today to present the value of International Medical Informatics Association, Nursing Informatics for a nurse, and how to use nursing workload measurement to promote nursing. Dr. Patrick, over to you.
Thank you very much. So I will share my screen. I hope it will work.
Yes, we can see your screen.
So do you have it on?
Yeah, we have it.
Okay, perfect. So thank you very much for inviting me to this conference, and thank you for the previous speaker who introduced the workload measurement, which I will continue in this. And as you said, I will give some, you had perhaps the video from Diane Skiba, our president of the IMIA Nursing Informatics before, and I will enforce what Diana says about the IMIA NI and the importance that we have the nurses working together for the benefit of the nursing profession as a whole. So we have country representative in the IMIA NI. Our theme for the next strategic plan, or the strategic plan started now, is to have nurses advocate their own profession around the world. We need to have a good collaboration among us across the world. The membership should be present and active in the group, and the excellence of the academic and the professional are to be shown as it is in this conference for sure. So the importance is, as says Diane, is cross-fertilization. We need to learn more from your experience and expertise in, for example, in Sri Lanka, because you have to face things that we don't have to face in Switzerland, I think, or I'm sure. So that's a need to have your expertise presented to conferences worldwide, recognized and going on. We need to sharing the strengths and the weakness of what we are doing, on what we are working, and what the process we are using now, to help the others to understand how it works and how we could go further. And of course, we need to promote the nursing competencies around the world. So that's the main points about the IMIA NI. Then I'll come back to Switzerland, and with the example that we are living now in Switzerland. So since 2012, the Swiss hospitals are financed based on DRGs. DRGs is a medical related diagnosis group, and it's the way that each case of the hospital are financed. DRGs are built up in medical diagnosis and medical interventions, and they claim that the nursing is included in the DRG, which is not really the case and could bring some problems. So the nursing activity are, so to say, included, but it is not the case, and we have to work on it to prove that in some cases the nursing activity is slightly different from the homogeneity of the DRGs. I don't know if you are using DRG in Sri Lanka, but it's quite interesting to see this situation. For example, I have one hospital here. You have the curve about the number of patients per DRGs, and if you put a line with the number of patients per DRG higher than 29, then you have only 194 DRGs who has more than 29 patients, and which represent 22,000 admissions, and the other 573 DRGs has only 4,700 admissions. So where we have really to work on to see what's the situation of the hospital is the first part, where we have a better number to see what's going on. So I took the most common DRG we have in these pictures, which is the newborns without complications. That's really the newborns not having any trouble, any complication. And this is the DRG curves with the number of the patients. And then you have the outliers threshold. That means that before every patient that stays one day at the hospitals are a low outlier. You have 53 here, and all the patients that are staying more than 6 days are the high outlier, with a bit more reimbursement, but not quite good. And you have the average length of stay at 3.8. So for the hospital, it means that every patient before 3.8 average length of stay are beneficial for the finance, and every patient that are after the 3.8 length of stay, then they are more costly for the hospitals. And that's important to notice that, because now the finance of the hospitals, the accounting, are pushing the medical and the nursing activity to have the patient out of the hospital before the threshold of the average length of stay, because they would like to have enough funds for them. I draw a box plot on these patients on this DRG with the nursing workload in minutes of nursing, and you certainly know that the box plot, the part in gray is the 75% of the patient that are all the patients that we have in this group. but we have a lot of outlier. All the dots you have over the gray box are the outlier. So that means that those newborn without complication, without anything, a lot of them has a workload for nurses very important. So the DRG has to say that is homogeneous, but if we look at the work of the nurses here, it's not homogeneous at all. And then we need to work on it to prove that there is it's not so easy to come to this conclusion. I have another DRG which is quite interesting. You have the 25% of the patients before the average length of stay, and you have 75% of the patients after the average length of stay. So that means that there is something very difficult to manage in the hospitals, and for sure you will have the direction comes to you and ask why all those patients are staying so long at the hospitals, what are the problems, and how we could manage it to do it better. So those two examples shows a typical situation, and we make a study in university hospitals where to see what are the discrepancy on the nursing care costs. So we evaluate the cost of the nursing. If you look at the first column, you have an intensive care units with an intensive care patients. And we have 97 cases in this first column. And the official reimbursement for the nurses, only for the nurses and not for the whole case, is about 82,000 Swiss francs. But the average cost of this nursing is 113,000 or 114,000 Swiss francs. So you have a big gap between the average costs and the reimbursements. You also could see that we have patients that cost more than 300,000 only for nursing costs in this DRG. So we need to have elements to document what is going on. And on the same dates, you could see that all the situation that are on the left side left side of the screen are a discrepancy in the DRG, in the nursing cost by DRG, and all the situation that are on the right side of the screen. These are the situation where we have less discrepancy, so we don't have to work on it. So we need to measure nursing, and how could we manage to measure the nursing? We need to have an electronic patient record, including nursing process. So with a classification that is in use in the whole country, that's our goal in Switzerland, to have a classification that is in use in all country, where we could have a good follow-up for nurses' needs. And in Switzerland, we adopt a local developed nursing workload classification called LEP. It is developed and maintained in Switzerland, which is important because we have seen that if we are using, for example, the nursing intervention classifications, the NIC, if we need to have adaptation on the situation of the country, it's really difficult to have it. So if we have a good workload classification in our own country, it's more easy to work on it, and the group of nurses could influence and go on saying, hey, they're missing something, we need to have more. So today we have more than 350 hospitals that are using the LEP classification in Switzerland, Germany, Austria, and Italy. The LEP system is linked with an assessment tool that is developed in Germany, which called EHSI, AC for acute care, and with NENDA International for diagnosis. So the process is the following. When you have the electronic patient record with the nursing process, you have a tool for making the assessment of the patient. You go to a diagnosis and goals, then you plan the cares, then you have the interventions that's coming, and of course you need to have an outcome and measure the outcome for to go back to the assessment. What we are proposing to the software vendors is to link the assessment direct with the planification and the intervention. So if we have patients that are staying for 1 or 2 days at the hospitals, you go directly to go from the assessment to the intervention to have all the information, because most of the time in these cases you have no time to go for the whole process. Then you could also link directly the assessment diagnosis with the planification, or you could go, depends on the length of stay of the patients, through the whole system. So that's what we are proposing. And to say again, we have for the assessment the EPA acute care system. Then we have the NENDA International Diagnosis system, and then we have the LEP, our nursing intervention process. So for example, the LEP, the measurement, the tools that we are using for workload measure the direct and indirect activity related to patients. There is also a measurement about the minimum value related to patients. It is actions that took less than 2 minutes. So we are putting in all together, and we have the activity not related to patients that we could measure. So activity not related to patients is to fill up the pharmacy of the ward and something like this. So we call this 2 parts the C. So you have A and C part, and then you need to have the schedule, the staffing of the personnel. So you have balanced and unbalanced staffing, saying that you could measure if you have newcomer in the ward, it's unbalanced staffing because you have new personnel and they are not strong as or efficient as someone who has habits in the system. So you could measure both of them. So I know my time is, my 15 minutes is over, so I will short it down. So there is a show about how we could use it in the system on a monthly base report. The red square, the red things is the number of days we have. It's a ward with here the example 19 days of measure. This means 19 patients we measure. The green one is the minutes of the nursing, the workload measured by LEP, and the blue and the red line are the nursing staff in minutes as well. So you could see that at the beginning of the month we have more work than the nursing staffing able to manage. So that shows that they have to do overtime to fulfill the goal we have it. And at the end of the day, you have a better situation. End of the month, sorry, better situation. And as the system is growing, the LEP classification is also moving not only to nurses, but we have built nutritionist classification, social worker, physiotherapist, midwife, etc. And now the physicians are asking, why can't we use the system to measure the workload of the physician as well? So it's a good point for us. And we could also use the system to measure the skill and the grade mix of a ward. So you don't need the same skills to manage everything's for the patients. You need to choose the best competencies for some of the activity, and some others are not necessary to have the best competencies to be fulfilled. So we need to promote efficiency and effectiveness in this situation, and the satisfaction of the staff and the patients are coming with a good repair. So the process about the skill and grade mix is a top-down where you analyze the activity, and then bottom-up when you analyze the process. So we took the same system, same database, and with the old LEP system, we could measure that we need 45% low qualified and 53% high qualified nurses. And in the red, you have the physician. And now with the better analysis and the development of the LEP, we could measure what is the part for the patients, 8.2%, the low qualified persons for 48%, then 13% for the middle qualification and high qualification. So if you could compare it by ward, you have the different ward, for example, nephrology or gynecology and maternity, the second row, and newborn, and so you could make the difference between one and the other of the system that we're using. So my time is over, and to summarize, with the introduction of the DRG in the nursing activities under surveillance now, and it was interesting to see that before the DRG introduction, we have difficulty to have money to develop the patient process, the nursing patient process, and with the DRG, they're now coming to help us to develop the nursing patient process, which is good for the nursing. So we need to have a good EPR to have all automated. You don't need to record the activity. The activity are linked to the nursing process, informatics nursing process. Then we need to have a benchmark across the country to see what the others are doing and how we could work it differently. And we really need to have a collaboration between DRG and nursing workload. So thank you very much. I hope it was understandable from outside.
Yes, Dr. Patrick.